Surgeons, and I am delighted to welcome you on behalf of the American College of Surgeons to this celebration that we have today here in Seattle. As you know, or at least some of you know, the American College of Surgeons is started approximately 8-9 months ago with this campaign that is being rolled through the cities of this country, which is the Inspiring Quality Campaign. You will hear a lot more about the Inspiring Quality Campaign, but the short of it is that this is a campaign to inspire quality, to invite surgeons to join the movement of quality, and to, with that, hopefully decrease the cost of medical care in this country and help our patients. In the state of Washington, we have had a quality campaign that has inspired many of you for quite some time. And many of you have joined the efforts of SCOPE, a grassroots efforts that was started with personal calls to many of the people in this room by Dr. Flum, which then mushroomed into a program that is a surveillance program, is a program that focuses on quality, and that now has integrated pretty much all the surgical services in the state. This is a unique aspect of our state, and we thought that it was very appropriate that we mix the launch of the Inspiring Quality Campaign, not with just words, but with the facts of what is being done in the state of Washington, what has been done in the state of Washington up until now, and what we will be doing and launching today in parallel with this Inspiring Quality Campaign, an effort that Tom Varghese and others will be discussing, which we call Strong for Surgery. The extension of that checklist that all of you successfully implemented and that has helped so many of our patients in the state so far. As we were planning to have this event, we thought, wouldn't it be great if we had something that was very, very much Northwest, very much state of Washington, and we thought perhaps we could go beyond the traditional aspects of surgery and surgeons talking to surgeons and nurses and other hospital personnel, and invited two industries that are located in Seattle and of which we are extraordinarily proud, and two industries that represent in a way everything that we are trying to sell the public today with the Inspiring Quality Campaign. They represent safety, they represent quality, they represent excellence, and we're very proud of them. So I was delighted when I approached two leaders in Boeing and in Alaska, and they agreed to participate here, and we're delighted for that. And what a great opportunity for us when Congressman McDermott, who is a physician himself, who, as many of you probably know, not only represents the 7th District in Washington, but has been a physician that served the community in the state of Washington for years, that served the community not just as a mental health care provider, but also as a state legislature during the 70s, and who is now in his 12th term as congressman in Washington, D.C. And he has agreed to open with some remarks his thoughts. He has been tirelessly working on behalf of our state and on behalf of patients, and we are delighted that he is going to join us. I want to warn you that his staff told me he had an important appointment and we could not have him today, and after I bent their arm, I had the congressman until 7 p.m. at which time, when he leaves, I want to make sure that you all understand, is because we had asked him to come at a time that was not very appropriate. And as you come here, sir, we would like, on behalf of the college, American College of Surgeons, to present you with this, which is our symbol, with the four aspects of quality as we see them here, to show you that we are in the process of decreasing the cost of healthcare, engage on that, and helping your work in Washington, D.C. Congressman, welcome to the college.
I ought to take it back to Washington and maybe give it to my colleagues. Maybe they could do a little bit better than we're doing right now in Washington, D.C. I want to thank Dr. Pellegrini for inviting me today, and thanks to the organizers, really, of this forum, which is really an opportunity to recognize the work of the American College of Surgeons, to promote quality across the country. I understand Seattle is the fourth stop. You started in Chicago, which is my hometown, where I went to medical school, and where the college is actually based, and then have been in San Diego and Baltimore. And it's really an honor to welcome you here to this, because it's an opportunity to recognize the surgeons at the University of Washington, of whom I'm very proud, because they have been leading this effort since 2005, and that they were there at the very beginning. And you ask yourself, what is it that really we're trying to do here? Well, it's applying to the practice of surgery the principle of quality and cost, and proving that they are not at odds with each other, but rather the key to increasing quality in medical care. The principle has been well known in leaders in the industry for decades, as you heard from both Boeing and Alaska Airlines. This principle that is being applied to medicine is not new. It is just new for us to begin as physicians, and it's only in recent years that it's been applied in medicine. Now, in my belief, it's more important now than ever before, because our country at long last has begun to move down the journey of achieving universal access for everyone in the country with quality and affordable health care. In a democratic society, in my view, that should be a basic right. There shouldn't be any question about whether it's available to everyone. And the Affordable Care Act of 2010 represented a huge step forward in that process, and much remains to be done in 2013. That's why I'm going back to Congress, because I want to be there when they finish it. Some people say, well, but what's going on in the Supreme Court? Don't worry, those justices know they have to do something that will work in the country, and I'm convinced that it's going to be upheld in June when they make their decision. Now, one of the greatest challenges we face in the Congress, access is a lot easier than the challenge of cost. Access, you just open the door and people come in. The cost question is a real one for us, and the costs of healthcare in this country has risen to the point where we're spending almost twice as much as they are spending in a lot of countries in the world, and getting better medical results than we're getting in this country. So there is no question that we are spending enough money today to really provide health care for everyone in a good way. The Affordable Care Act only provides some of the answers. It's not everything. And in this context, the Strong for Surgery initiative by the American College could not be more timely or relevant to the challenges that we face in this country. We cannot allow healthcare costs to continue the way they've been going. There is simply going to be a backlash at some point, at some level, in some form, and I think that it's good when physicians are leading the changes that are being made in this society. Now, this builds on the pioneering work that's been going on for almost 10 years, which was led by a multi-hospital collaborative, the Surgical Care Outcomes and Assessment Program, or SCOPE for those of you who like acronyms. It's been essentially successful in deploying a checklist like pilots use before they leave the ground. You watch when you go out to the airport and get on the plane, pilot comes out of the cockpit, goes out, goes down on the jetway, goes down, walks around, looks at the tires, looks at that checklist that he's going through is essentially what we're talking about here. We are saying that we as physicians ought to be more systematic about this whole issue, and the result has been significantly reduced surgical complications and deaths and significantly reduced cost. We have already demonstrated that this can work. A few years ago, when Don Berwick was at the helm of the Institute for Healthcare Improvement back at CMS in DC, he said, "I cannot recall a clinical care innovation in the last 30 years that has shown the results of the magnitude demonstrated by the surgical checklist." that is the word of somebody who's been involved in quality assurance all for very many years, and somebody who's been right at the pinnacle of seeing what's going on. Now, it's no surprise that in 2008 this idea became the focus of an 8-country study sponsored by the World Health Organization and the Harvard School of Public Health. It's exciting that the idea that will be now carried into doctors' offices and the pre-surgical environment through the strong surgery campaign of the American College began right here in Seattle. I'd like to also quote Dr. David Flum, who's from the University of Washington, whose initiative launched SCOPA. He's someplace here. I guess he'll be up here in a few minutes. There he is, right here in the middle. 2 years ago in the Seattle Times, he said, "This was a grassroots initiative. It is not something the insurance companies made us do, or that the Department of Health and Human Services in Washington, D.C. forced us to do. It's something that came out of the profession." And that's why you should all be proud of it and pleased. Now, as a legislator for over 40 years, I know that without grassroots initiatives, no good idea becomes a law. Good ideas come from the people who are doing it, and they bring it to people like us. And what you're doing in this is showing Washington, D.C. that the grassroots has a lot of good ideas, and it's going to be important because as we go into the implementation phase of the Affordable Care Act, it's going to be important that you all be involved in thinking about what you can add to that. I want to add my voice finally in admiration and support for the learning partnership demonstrated here tonight, a partnership between our state's healthcare community and our aviation industry. As I mentioned, Boeing and Alaska are here. These partners will bring to the table 3 key themes in the innovative work of increasing quality and reducing costs. They are safety, standardizing, and simulation. And I regret that I've got to leave here. I'd like to hear it all talked about, but I can't tell you how exciting it is to be able to go back to Washington and say the best idea for controlling costs started in my state by my own physicians in my own university hospital. Because this idea of a checklist seems simple. Somebody might say, why didn't we always do that? Well, you know surgeons. They all know what's best, right? This is an admission by the profession. We're going to listen to each other and watch and count. So we got data that we can actually point to and say, if you do this, it isn't going to work. That will work. So I'm very pleased to be here tonight, and thank you very much for giving me a moment.
Thank you, Congressman, for your comments. Great feeling, David. So with that, I would like to invite David Hoyt, who is the Executive Director of the American College of Surgeons, to come forward. Most of you know David. David is a trauma surgeon who worked most of his life in San Diego in one of the best trauma systems that exist in the country. And then he moved to Irvine as chair of the Department of Surgery. And I take a little bit of credit as one of the regents in the college who then, when we were looking for an executive director, felt that David embodied everything that we wanted to have. David has worked in the college for 2 years. I had the privilege of being chair of the Board of Regents when he was working at the college and working with David every single day very closely. I can assure you, he is a tireless, energetic worker that has taken the college to a different level. And the level that he's taking it is in fact quality and is in fact decrease and control of costs. David?
Good evening. Thanks, Carlos. It's really a privilege to be here with you, and I want to congratulate Dr. Pellegrini and Dr. Flum and the organizers. I'm going to make a few comments that really build off what we just heard. And if you look at our college over the last 100 years, we have defined our mission based on setting standards. We did this as early as 1917. Those ultimately became the Joint Commission, which spun out of the college in 1951. And progressively, through the Commission on Cancer, the Committee on Trauma, Bariatric Surgery, etc., we have committed to these programs. Now from that, we've really learned 4 principles, and you've seen these principles embodied in some of our displays and the cubes at your seats. But basically, the first is to establish standards for whatever you're talking about, based on research when you can, consensus when you can't. The second is to build out the infrastructure to support that programmatically. The third is to commit to performance measurement through databases that are appropriate and designed. And the fourth is to submit yourself to external peer review. There's no higher standard. It is the good housekeeping seal of approval, and it is our commitment to patients to go through these steps. Now, I can't think of a better example really to introduce this than a trauma system. And Ron Mayer, who's on the faculty at the University of Washington, has been instrumental. The state of Washington has been instrumental in setting the standards for the country as a disease management model. So these principles we've lived by in Seattle and Washington have provided leadership throughout. Now, for the first time, there's alignment in Washington amongst the largest payers, CMS, and through our think tank at a national level, the Institute of Medicine, there is a quality improvement commitment that in the last year has reflected itself through the National Strategy for Quality Improvement from Secretary Sebelius' office, through the Triple Aim, which came from Don Berwick's tenure at CMS, and the concept of a learning healthcare system. And this is a major initiative and a major pressure that's affecting us all in healthcare. Now, who has a learning healthcare system? Well, I would argue that the American College of Surgeons is the perfect prototype of this concept. Again, using best evidence to define standards, using those standards to define, in turn, outcome measurement through databases, the commitment to build those, and then using the results of that to reform either clinical trials or redefine best evidence. In addition, innovation and new technology can be introduced through this model. And again, I'm going to mention in a moment how that has been introduced through the efforts of things that have come out of Seattle as well. Now, the other major pressure on us today is the cost one. And we all know these numbers. If we don't do something by 2020, we're talking potentially 20% of the gross domestic product. If you take the revenue generated currently by all forms of federal government and look at the expense, the numbers are really shown here. And we collect about 18% of gross national product. And currently on Medicare, Social Security, and the interest on our debt, we're spending about 16%. What that really is creating, and I think you're seeing this in Washington, we're certainly all feeling it personally, is really a concept that Dr. Reinhardt, who's a somewhat controversial economist at Princeton, has called the net social value of healthcare. And he simply says the net social value is the actual gross value added by the healthcare to patients minus the opportunity cost to society. So we're really having a discussion as we think about this as to what's going to suffer if we don't do something to curtail costs. Well, we all feel that responsibility, and today I think I'd like to show you an example of how you can bring this concept very pragmatically together to improve quality and lower costs. And the example of the SCOPE project in Seattle and Washington is another wonderful example. The example I'm going to show you is based on the NSQIP program, which is a database developed in the VA system, transferred into the public sector through the American College of Surgeons about 10 years ago. And essentially what it does is it allows you to profile hospitals against each other against a particular complication. So here you see graphically a caterpillar graph, so-called, where you have, let's say, surgical infection being reported. And on the right, in red, you have hospitals that are performing less well than you would expect, and on the left, in green, you have hospitals performing better. What this does to physicians when they see this is that it helps the hospitals in red to ask themselves what can they do to improve their performance. And they go to the hospitals in green and they ask and they get best practice. And that's the concept that really has been the basis of what I'm going to show you. It's a very similar concept that I'm sure Dr. Flum will talk about in terms of the improvement strategies that come out of SCOPE. Now, we've studied this. This is a paper by Bruce Hall and Cliff Coe, who've been instrumental in this NSQIP program. And they've demonstrated that if you put this program in place, and then study over several years the performance effect, that you reduce complications, you reduce mortality, and it works out to about 1 complication per day in a 400-bed hospital. That's believable. If you translate that into dollars saved, and you reduce the cost of a complication each day by about $11,000, then what you're really looking at from a cost savings for an average hospital is somewhere between $3 and $5 million. You spread that to all the hospitals in the United States, and you're really talking about billions of dollars. So this is one thing that's real, that's deliverable, and it's why we're really trying to get everybody involved. Now, the other derivative of this is the collaboratives that are developing, and there's several that have developed around NISQIP. I can't think of really a better example, though, than the application of these pillars as in the state of Washington. And again, under the leadership of Dr. Flum and many of you here today, the SCOPE project now really does represent a statewide effort toward quality improvement. And in fact, there are results now being published to show the very similar kinds of effects, that this leads not only to improvement in quality, but a reduction in cost. This is real. This is something we all need to get behind. This is something that we can actively bring to the discussion about healthcare in this country. Now finally, we don't often think of quality and education necessarily linked, but I think increasingly the responsibility, the bond we have with our patients is really to demonstrate that we know what we're doing and that our educational efforts are really preparing us to provide the best quality care. And again, leadership from Dr. Pellegrini, our education division, Dr. Sachativa, has developed an accreditation education institute program across this country. There are now 65 institutes where surgeons are being trained in new procedures, they're being reaffirmed in existing procedures, and this is the model for the future of how does a patient know we're qualified to do a procedure. It's really the public trust, and again, it's part of the Inspiring Quality campaign. I would argue that the surgeon of the future is going to increasingly be parts of teams, systems of care. We're going to be held to a standard of evidence-based practice, even public reporting, and recertification is going to have to be tailored to our practice. And as a result, we're really seeing a shift in our sense of responsibility or professionalism from the past, when we could do things by assertion and control, but today we really need to do things by being accountable through collaboration and evidence. This is in fact the basis of our Inspiring Quality campaign. We are now then using this as our form of advocacy, both at a federal level and at the local level, as we're doing today. And it's really attempting, if you will, to inspire in others the commitment to quality. I just want to end with this little video then, and I think this summarizes it, and hopefully you'll find it interesting. And again, I want to thank everybody here for coming today, and particularly Dr. Pellegrini and Dr. Flum for putting this together.
It's my pleasure now to introduce our next set of speakers, two speakers that are from the aviation industry. And I would first like to introduce to you Brad Tilden. Brad, as you probably read in the Seattle Times about 2 or 3 weeks ago, became the CEO of Alaska Air Group. He was president first of Alaska Airlines, one portion of Alaska Air Group. And if you really wanted to be amused, I can tell you, and I can tell you in front of you because it is the absolute truth. My acquaintance with Brad occurred because he was making, as president of the airline, calls to customers that flew frequently in Alaska to just ask the question, how was your flight? What are we doing that we could do better for you? That was the president of the airline. I was so touched by the fact that this person at that level would reach out to a customer that flew frequently and said, how are we doing for you? That I suggested that we meet. And I have a special passion for aviation and airlines, and I'm so happy to tell you today that that flourished into a great friendship in my meeting a lot of the team at Alaska and a great admiration for the 7th largest airline in the United States, which is based in Seattle. And Brad is going to tell us a little bit about quality and safety in the airline. Brad?
Thanks, Carlos. Hi, everybody. Good evening. It's I have to tell you that I'm very honored and more than a little intimidated to be in the room with all of this intellect and education and passion and people that are giving their lives to helping other people. It's honestly quite an honor. I don't spend many nights in rooms like this, so thank you for having me. So Carlos kind of told you how is it that Brad ended up here with all these surgeons and doctors and so forth. Carlos told you how we met, and it's been a fabulous friendship. And I think that I hope that I know that you're going to help Alaska Air Group. I hope that we're able to help you. We've got a huge common interest. Alaska's got a lot of employees here. We want to ensure that our employees have access to good quality health care, to safe health care. And if there's something that we can share along the lines of best practices, we're happy to do that. One of the things, so what's in common between aviation and hospitals? Safety is critical to both of us. Both of us, your patients, our customers, place their lives in our hands. I think there are a lot of similarities. People have talked about checklists 2 or 3 times already. I think there's a big difference too, and I just want to kind of acknowledge that out of the gate here. The airplane doesn't have to take off. If the airplane's not maintained, if it's not perfect, if the crew's not ready, we'll just say we're staying. And probably some of you have been at the airport when we made that decision, and I apologize for that. But I was speaking to Tom earlier, and if the helicopter lands on the roof and the patient's been in an accident, you guys don't have that luxury. So I just want to kind of acknowledge that out of the gate. What are the parallels? I thought I might you guys yank me when it's time, but I just thought I might tell you from my perspective what are 5 parallels between aviation and healthcare that I've seen. The first one we've talked about is just the fact that both your patients, our customers, do put their lives in our hands. It's a grave and important responsibility. That's a big similarity. Second one is teamwork, and I noticed that on the video just now, but teamwork is essential. For us to prepare a flight plan involves 4 or 5 different departments. It's a simple flight plan. It's hey, we're gonna go Seattle, Chicago. It's the scheduling department. We have an outside company that we work for with meteorology and weather. We've got to have input from those folks. There's a load planning department that how many passengers, how much fuel, how much cargo, how many bags, how much that, to get the weight of the airplane right. There's dispatchers that kind of bring all of this information together and say, and make the final conclusions of how we're going to load the airplane and fuel it and so forth, what route the airplane's going to fly. And then the flight crew gets involved. And it's teamwork, all of those folks that come together to make this happen. And it's important. What happens if it's wrong? What happens if you're on that Maui flight and there's made a mistake? Not enough fuel. What happens if the airplane's overloaded? What happens if the center of gravity is too far forward, too far aft? It's important stuff, and so teamwork is really really vital. I thought I might share a personal example from medicine, or from your world. I've had the good fortune to be very healthy my whole life. I actually just had a very minor thing done on my nose at Virginia Mason. And I have to tell you, I was amazed by the teamwork there. And people say, Brad, how was your surgery? I said, it was great. And that's not what they expected, but it's an amazing, and I'm sure all of your institutions are similar, but the whole sense of folks when they came in, the pre-op, the admission, the briefing that the anesthesiologist did, and the nurse anesthetist, and I'm sure I'm mispronouncing the name, the doc that came in and did this, you go into the post-op, you had the complete sense that they all knew my situation, that they were communicating with each other, there was a common interest by all of them. It gave you a really, really good feeling. So that's one parallel I see. Teamwork's important in aviation. Teamwork is important in the world that you guys have. What's another one? And I sat around with some folks in Alaska. I think we could do 15 of these if we wanted to. I just chose to talk about 5. There's a system of double checks in aviation. And I imagine that surgeons have the same sort of thing. And one quick example is the pilots in flight, if they're talking to air traffic control. And they might say, air traffic control might say, hey, Alaska Flight 81, descend and maintain 10,000 feet. What do? There's a flying pilot and there's a non-flying pilot. The flying pilot will, if he hears right, he will actually start a very gradual descent. The non-flying pilot will say, air traffic control, Alaska 81, descend and maintain 10,000 feet. And they'll confirm that they hear that. There's a mode control panel out, so they verify. There's a mode control panel on the airplane where they load in 10,000 feet so that an alarm will go off if we fly through that altitude. After the non-flying pilot does that, he touches it. And that touches it, that's verifying it. And the flying pilot will say, check. He'll say, we got that right. So we verify the information. I want to get my words for this right. Verbalize the information. Then we verify it. Then we monitor. All 3. What happens if we didn't hear it right? If the pilot that's talking to air traffic control was it 10,000? Was it 12,000 feet? Does he ask the flying pilot? No, that wouldn't be a double check, would it? That only one person knows the altitude. They'll go to air traffic control. Say again. Tell us the altitude again. Air traffic control will repeat it. Then you have 2 people checking everything with the altitude. I'm not sure if that all made sense, but what I'm trying to say is you try to get it right. System of double checks. We've talked a lot about checklists. I called our chief pilot before I came down here and I said, hey, how many checklists are there on an average flight? There are 11 checklists on a perfectly normal flight. If it's the last flight of the day, there are 12. If there's an emergency or an irregularity, there's far more. There's a before start checklist, a prior to pushback checklist, a clear for start, an after start, a takeoff checklist, an after takeoff, descent checklist, approach checklist, landing checklist, a shutdown checklist, and a secure checklist. Now, is that because they do that? Why do they do that? Congressman McDermott said it. Standardization. The quality comes from the standardization. Pilots have a lot of ego, but they know that we are safe because of the use of these checklists. I fly little airplanes. I fly Cessna 182s. I was out flying around Seattle over the weekend. I don't have 11 checklists, but I've got 6 or 7, and you do it every time just so that there's important procedures you want to make sure that you get them every single time. The final one, or the 5 that I was going to talk to, it kind of has just the way us human beings are. We make mistakes. Alaska Airlines makes mistakes. And there's a couple of things to talk about here. The culture, it's one of the things we recognize, and you guys know we had a bad accident in the year 2000. One of the things that you recognize in terms of the culture is you got to be able to talk about mistakes and make the culture safe for people to bring that stuff up so that you can improve. And that's one of the things, and I don't know what your profession's like, but in our world we have what's called ASAP programs. And if an employee, if it's not gross negligence or intentional or something like that, they say, hey, I made a mistake, they're protected. And that's really, really important so that we can know what happened so that we can make things better. A similar angle on this we call human factors is how did we design the procedure? Did we design the procedure so that it's kind of, the two terms sound the same, or two procedures that are supposed to be different? Are they similar enough to confuse people? What sort of human factors elements do we have into the thing and that could lead people to mistakes? Is this making sense? One example of this is a normal engine start procedure. We start with the right engine first. And then once the right engine is going, then we move to the left engine. If the auxiliary power unit's not working, which is how you normally start these engines, if we're using an air cart, we start with the number one engine first. It makes no sense. These engines are dangerous. You don't want people around them, and the pilots, one time you start the number two engine first, one time you start the number one engine first. So people looked at it and said, hey, we're asking for a problem here. Someone's going to be standing by the wrong engine where we're trying to start this airplane. So we're changing that right now. So every time we'll start the number one engine first and the number two. But I bet you guys deal with this stuff. It's just the way flows are designed, the way procedures are designed. In our mind, when we have an error, it's just the way we would think in aviation. Either the process is wrong, and we find that. We're an 80-year-old company. We can find times the process is wrong and you do need to change it, or we didn't follow the process. It's got to be one of those two. That's kind of how we think of things. That's what I have to say. I do want to thank you guys for what you're doing. We're really honored to be here with the American College of Surgeons supporting you with this Inspiring Quality campaign. I want to thank you, if a couple of you are Alaska Airlines customers, I want to thank you for your business and wish you all the best. Okay, Carlos, thank you.
Thank you, Brad, very much. I like those apologies. And I like when you said we do something wrong. You know, it's kind of hard to see people saying we do sometimes things wrong. That's the way you start correcting things. Our next speaker, and we hope the idea of having Alaska and Boeing is to solidify this nascent partnership that we're establishing with them. Where is it going to take us? What shape it's going to take? I don't know. But I think as we find things in common, we're going to make progress. So our next speaker is Keith Leverkern, and my relationship with him was a lot shorter than Brad's because we wanted to have a leader from the Boeing company, and as I checked around this person, everybody said, if you hear him talk, you will love what he has to say. It's right up your alley. And we were delighted that he accepted to come here. He's vice president for Boeing, and his area of specialty is jet propulsion. Those are the little engines that keep the airplanes flying. He has done a tremendous amount of work in the area of developing processes within Boeing. And in my conversations with him, I became so excited that I am planning now to go visit the factory with him to see exactly what he means when he says we have shortened the base and we're making more 777s than we did before. Keith, thank you for coming.
Thank you. Well, now that Brad's gone first, my speech has gotten to be about 30 seconds long. Maybe we should have talked a little bit about what we were going to say. No, you know, Carlos called, and like Brad, my first reaction was, now let's talk about this. Surgeons building airplanes, surgical outcomes, engineering outcomes at Boeing. Trying to seek that area of commonality, and the more I stewed on this, of course, it became clear that while there are, as Brad points out, many, many differences, in determining this cost of quality as well as assuring safe outcomes, there are probably more similarities than we would consider. You know, we are coming up on our 100th anniversary. Boeing will be 100 years old in 2016. And I think that's something that we're very, very proud of. And it's not too many U.S. industries that actually survive that long. So when we look back at that heritage, we recognize that there's a Boeing brand that's been built, and it's almost been by, I would say, brand from a, if you view it from a strict marketing standpoint, it's almost been by accident. But there are fundamental pillars to that brand. And when you just look back on the 100 years, these iconic products like the B-17 bomber that helped to win World War II. That's right, we didn't have B-17s in World War I. We did have Boeings. But we also think about the introduction of the jet age with the 707, 747. You all know this. And while many of you are Alaska customers, I would venture a guess that almost all of you are Boeing customers. So we would also invite your feedback on our products. When I talk about brand, I think that when you really think about Boeing, if I were to just ask you to popcorn what the Boeing brand meant, I think I might hear things like solid, dependable, safe, and all those things are true. And we have learned in many respects through the hard way, but also through iterative standardization, how to assure that safety is now almost written out of the flying public's mind. That there are very few people who are getting on an Alaska 737 and wondering if they're going to make it to their destination. That's really not what we're thinking about anymore. We're thinking about, am I going to have enough overhead bin space so that I can put my carry-on? Am I going to be able to get a drink in time? Am I going to be able to arrive on time? These are not, safety has now not even entered into the vernacular except for the population, the very sensitive, and my wife. So, but really that's now something that is just accepted as a requirement to be a participant in this industry. You cannot enter in if you decrement safety from where we're at right now. How have we gotten there? We have gotten there through standardization of our design practices, standardization of our requirements, and standardization of our build processes. And it is absolutely intrinsic to what we do to make sure that those processes are intact and they are adhered to. Today, 3 million passengers just today, 3 million passengers flew on 42,300 flights on Boeing airplanes. I think that's remarkable. I think that's a remarkable statistic. I think we also have to look at where we've been. In the 50s and 60s, the aircraft fatality, effectively the aircraft crash rate, where fatalities were occurred, was 1 in 200,000 flights. 1 in every 200,000 flights in the 50s and 60s resulted in a fatality. Today, that's less than 1 in 2 million flights. That's occurred over a relatively short span, and that is really due to the cooperation between the airlines and Boeing and our supply base to assure that those standards and the standardization of our processes are met. Some of the things that are now touchstones for us in the industry, but have really been learned over the past, and frankly, I would say that these have been developed over the past 50 years, because you can think about the exponential growth in the technology between World War II, the beginning of the jet age to now. Can I see a show? How many of you know that you've flown on a 707 before? All right, good. Many of you. The dawn of the jet age. Some of these requirements that have now just become standard is, and perhaps one of our greatest ones, is that no single failure or probable combination of failures will result in a catastrophe. Okay? No single failure on an aircraft will result in a catastrophe, or probable combination of failures. So, how do we do this? The airplane is an extremely complex system, you know this, but now we have to dissect each system down to its constituent levels and say, if A fails, and then B fails, and then in an unrelated system A fails, we have to make sure that when we build those fault trees, that a catastrophe isn't going to occur. Similarly on critical structure. We know what the design loads are going to be when we fly through a storm, when we have a hard landing, when we design for a very specific loading case. We have to design the structure to be 50% stronger than that. And that's something that is inviolate. We do not back off of that, even though if we built it out of hog iron and I-beams, we know we could do it, but in fact we actually have to get them in the air. So this is a relentless pursuit even with those fixed standards in place. How do we now comply with those standards in an innovative way? And I think that brings me to the next pillar of the Boeing brand, and that is a relentless pursuit of relevant innovation. Not innovation for its own sake, but innovation that Mr. Tilden and his airline are actually going to be able to bank when they receive the product. How do we reduce operating costs? How do we reduce fuel burn? How do we assure that the training that the pilots have to go through from one aircraft type to another is minimized? These are the innovations that we've experienced in the industry, and again, it has to be based on what the operator expects and what they're going to need. One example I'd like to give, how many of you, this is the audience participation part, how many of you know what, and Mr. Tilden excluded, how many of you are aware of how many 737s we build out of our Renton factory every month? Does anyone know? Any?
Between 33 and 42.
Yeah, that's a pretty wide band, but that's right.
It's changing, I understand.
Yeah, it is. You're absolutely right. We have just transitioned from 31 a month to 35 a month. And because the demand is so great for the product, there are views to taking that airplane rate higher. I want to talk a little bit about innovation and how we standardize innovation. Now, the idea of innovating on that 37 line at 35 a month, 35 a month, that's greater than one a day. We developed the new Boeing Sky interior, and that is a new architecture on the interior of the airplanes, new stow bins, new lighting, have any of you seen this? Any of you had the opportunity to fly it? What did you think?
Beautiful.
Yeah, it really does something different to the cabin. And now, 31 a month, and we're going to introduce new innovation in 31 a month. Boy, we better have it right. We better have it right. So we have established standardized processes for how we introduce innovation into the market, as well as just recently we certified a brand new engine derivative on the 737, delivers 2% fuel burn betterment, and oh, by the way, we did it in the middle of 31 a month. So the idea of standardization and innovation being in conflict couldn't be further from the truth. They're absolutely interdependent. And in fact, if you haven't standardized on innovation, then frankly, you end up with something like our recent experience is on the 787. The 787 is going to be a remarkable airplane. In fact, it is a remarkable airplane. We've got it now in the hands of the customers who are finding out that the passengers love the aircraft. It is the first all-composite carbon fiber aircraft in the transport category. It's the first all-electric airplane, meaning that the air from inside the cabin actually comes from an electric generator as opposed to air from the engines, meaning the engines are more efficient. The cabin altitude is lower. It's humidified. Currently, Alaska, when they fly their 737s, they have to do inspections every so often because aluminum will fatigue. And that's just the nature of aluminum. In composites, that's not the case. So we can go longer between inspections. It's a wonderful airplane, and it's 3 years late. Innovation is hard, but the reason, one of the key reasons that it is 3 years late is that we neglected the standardization of innovation and how to introduce it. I would suggest to you that many of the things and the decisions we took on the 787 were varied away from the tried and true practices that we have in our product development, gated process, what we call. So now we're recovering, and the Boeing brand has taken a bit of a hit because we dissatisfied our customers by being late. So I believe that we now have tremendous amount of work to do in order to rebuild that brand and assure ourselves that that innovation standardization is now in place for our next set of airplanes, the 737 MAX, perhaps a new 777, a new 87 derivative. These are important lessons learned, and by the way, we're not afraid to admit them. And now we just have to get to it and understand where we failed and ensure that that standardization gets built in. Last word, the cost of quality. I want to tell you that when I ask a group of engineers and say, let's go, we would like to get 25% out of cost out of the product. Do you know how many volunteers I get? None. That's not what engineers want to do. I don't want to get cost out. If I say, hey, let's go improve our quality by 25%, well, okay, if I'm forced. But if I say, the only way that we're going to achieve 35 a month, 42 a month, and beyond is that I've got to get quality in early, and I have to get flow out, and I have to do it inside the footprint that I've got. Now, that's like an Apollo 13 challenge at that point. And they say, right, let's go. But guess what? Flow and quality are proxies for cost. Let's get the cost out by putting the quality in early, eliminate the rework loops at the end, and guess what? Cost is an outcome. Cost is an outcome. So our future challenges are, how are we going to reduce the costs of developing the future airplane? Because the costs of developing the 787 were nearly 3 times the 767, engineering hours to do it. And that's with more sophisticated tools. So how do I take advantage of the tools so that I'm actually getting cost out? How do I assure that we don't stray away from the imperatives of standardization around innovation? These are the challenges that we face in the future, and we haven't got all of the answers yet. There is no specific playbook, but we look forward to that future and understanding what the past has taught us. So thank you again for the invitation, Dr. Pellegrini.
Thank you so much, Keith. Didn't it seem like when he talked about the flow and somebody gets a complication of all the problems that happen, I'm sure that most of you thought the same thing I did. This looks like a patient that had a little complication, either the readmission, then the x-rays, then the x-ray showed this, then you do this, then all this type of problems. So we do have similarities, we have to learn from each other. It's my pleasure now to introduce David Flum, who I am sure all of you know very well, so I won't give David's CV for you, but I will take this opportunity instead to thank David on behalf of the community, not the University of Washington alone, but on behalf of the community of surgeons in this country and of physicians in general, because I think that David chose a path in his life to devote his life to the improvement of quality, and to do that by grassroots efforts, by working with individuals here and there to make quality the outcome of his work. I work with David every day, and I can tell you that it is a challenge. Somebody ought to congratulate me. But it's a real kind of challenge that a person like me has, because it's every day David has a new idea, and every day I say, no, you gotta be kidding, how can you get there? And then when you start thinking about it, the idea is right. David?
Well, great. Thank you for that very kind, I think, introduction. And it's really great. It's so great to be here. And this is really a great night of partnerships, right? Where we just heard that great talk about aviation. There's 2 great talks about aviation. And you know, hearing them talk about how they innovate with standardization, what a challenge to us as surgeons, right? And this great partnership with the College of Surgeons, you know, they've now stood behind SCOPE, even though the NISCOP initiative is really a national initiative, and stood behind the Strong for Surgery program that we're going to talk about in a little bit, which is now actually going to be led by the college's education division. And lastly, it's really a partnership of the people in this room. So audience participation. Look to your right for a second, okay? And now look over towards your left. Those are the people who built SCOPE. SCOPE's not one person, it's not one picture on a map. That's a silly way to think about it, frankly. Because none of it happens unless on the other end of a phone call, Rick Thirlby, or Mike Florence, or Mark Horton, or any of you in this room, Bellingham, Maury Johnson, any of you pick up the call and say, you know what, I'm willing to do that because that sounds like a good idea. It sounds like a crazy idea, but yeah, we'll get every hospital in the state of Washington to volunteer to be part of something where we show each other our worst outcomes and we try to learn from each other. That's inspiring. That's really inspiring. And that's inspiring quality, and that's what the college is about tonight, and it's something we can all be really proud of. So let me tell you about this aviation theme a little bit from my perspective. I'm flying back from Tucson about a month and a half ago. My flight's delayed. I'm looking out the window, watching them. Actually, a guy's on the wing, pulling open the side of the fuselage and pulling tubes out and whatever they do. No offense, but that's what it looks like to me. And the fella next to me is narrating on the phone. They're saying it's 20 minutes, but it's going to be more like 2.5 hours delayed. And I said, wow, you seem to know what you're talking about. What's going on out there? And I see that these two guys, one guy's pulling the tubes out, and there's a guy behind him on a cherry picker going through a little bit of a list, holding a clipboard in his hand. I said, what's that? What's going on? He said, oh, what they're doing is the guy with the clipboard is supervising the other guy. He's checking him. I said, I can't imagine that in my field, like if there was something going wrong, that somebody would be checking me, and I don't know if I'd like that. He's like, well, what field do you work in? I was like, I'm a surgeon. He's like, oh, I get it. He's like, I'm an aviation maintenance manager. See, in my field, lives depend on it. We have to check on each other. And so that was ironic, and, right, and also a little kind of bittersweet because he didn't even think I got it. He didn't even think I could understand that there could be a field that tried to work to mitigate variation to the point that it didn't hurt me or my wife or my family or a patient. And that's a challenge we need to own. So aviation. We think about aviation as like, that's the ultimate industry, right? Part of it's blue smoke and mirrors. They actually have a variation problem. They really do. There's not one plane that flies and crashes as often as the other. They have variation in those rates. I can show you the list. It's scary, actually, to see which planes crash more often than the others. There's actually another list, another picture I should show you, of all the airlines and their crash rates. They're not the same. They're not the same. But not a one of us wonders when we get on Delta or, you know, Pan Am, or that doesn't exist anymore. I was trying to find a safe airline. Definitely not Alaska. That's not the problem. You can't imagine how much variation there is. But none of us think about it. We don't even care. We just care, are they going to give us peanuts or pretzels? That's all we care about. That's a field that figured out how to protect their brand. Not to make variation go away, but to make it so it went away for us, so we don't have to care about it. That's remarkable. Before we started SCOPE, before the people in this room started SCOPE, this is what it looked like in Washington State. Each dot being a different hospital. The complication rate I'm showing you shows the variation between the different hospitals. You know, I could show you anything. I could show you the cost of care, the length of care, the reasons why we're doing care, variation that's toxic variability that exists in healthcare. And people don't just care about the peanuts and the pretzels when they go in a hospital. They're scared, and they're scared to death. That's the dynamic when we started SCOPE. SCOPE was really created to address this thing, and it's remarkable. You know, we could talk about, you know, how it happens, but basically a phone call happened between me and Rick Thurlby and Mike Florence and Maury Johnson, and you got it. That's the way it happened. And before long, the hospitals in the rural part of the state and the urban part of the state, the most busiest part of the state and the smallest hospitals, the blue part, the red part, they got together and said, you know what, it's the right thing to do, to find out what we do, to track on variation, to figure out how we can learn from Spokane if we're in Seattle, and Wenatchee if we're in Bellingham. And that's been a pretty remarkable ride. And you know, just shining a spotlight on variability helps improve quality, you know that. But we've been doing things that have really been important here. Asking surgeons, colorectal surgeons in this case, what would you do differently every time if you could? They say you should, in a colon operation, always check for a leak, like you check to see if your kid's tire is sealed before you put it back in the tire. And you know, when we started in SCOPE, about half the time, surgeons checked for leaking. Look what's happened quarter by quarter by quarter by quarter. Now 95% of the time, we're checking for leaks in the operating room, dropping the risk of leak by half. You know, that's the kind of thing we wrapped into a checklist, something we could all be proud of, a checklist initiative, 50 little points that you start on before you start the case. And that's a great thing. I don't want to minimize how important that was because, you know, it's not just hanging a piece of paper on the wall. It's getting your colleagues to change. It's getting your colleagues to take it seriously. And that work is not done. I get it. It's hard work. It's hard to take it seriously. It's hard to change the culture. But it's work that we created in Washington State. It's something we can be really, really proud of. Variability dropped. Not by accident. We worked hard on it. It went from 17% down to 9.5%. The variability is still there. When we can make that variability go away so all you care about is the peanuts or the pretzels, it'll be great. We're not there yet, but boy, we've made huge progress, and that's something to be incredibly proud of in Washington. And you've seen the cost numbers. I care about these, but there are other people who really care about these, and that's the people that we've been trying to tell the story to, that this is something they should support. Now, SCOPE has gone far, and we should be incredibly proud of SCOPE, but building a quality improvement initiative for the long haul, you need some more legs than just the good graces of hospitals willing to spend a little extra money. And so over the last 2 years, we've been building a network called CERTAIN. And some of you have heard about that, but I encourage you to check out this website, becertain.org. It's incredible. Basically, it is the approach to get research funding to support the quality improvement that all of us need and want in Washington State. It was the idea that surgeons working with surgeons is a good start, but bringing in the public, bringing in the payers, bringing in all the stakeholders that are involved in care and building it off the backs of research is something that would really be a lasting initiative. And sure enough, we took this amazing network and started linking it. We started linking it for automated data records. We started linking it with the idea of IRBs, of researchers working together, of creating a learning healthcare system. So if something great happens in Spokane and they figure out how a new stapler is not working, we can know about it in Aberdeen or Olympia or Longview. That's a learning healthcare network. We linked in things like payer data and things like pharmacy claims and a whole new approach where we gather patients' voices and literally ask them, what's it like in 3 months after this operation? We've linked in ER clinics and we've linked in non-operative places so we can finally compare surgery and non-operative care and learn which of our operations are actually making our patients feel better. And lastly, we have new partners, the patients and the payers and the policymakers, and this is really a great network. You're going to hear in a moment from Tom Varghese about Strong for Surgery. It's one of the certain initiatives that says, you know, we need to actually do more than just shine a spotlight on variability. We need to dig in and make changes, and we need to change each other by changing the culture. Strong for Surgery, if you wanted to reduce it to its simplest thing, take the idea of checklists and move it to where decisions are mostly being made before patients get to the hospital. There would never be a plane that would start a checklist when the plane is already running down the track. It's silly. You got to start dealing with decision making before a patient gets to the operating room, because the die is cast by the time a patient gets to the OR. We all know that. Decisions about should they have the operation in the first place? Decisions about is this patient strong enough nutritionally? Is their diabetes controlled? Is their heart protected? These are all things that we need to think about and standardize, and we haven't even ever gone there. The last domain of the Wild West is what happens in the doctor's office. This is where Strong for Surgery is going. And you know what? It's a bold idea. I get it. I get it that it's kind of crazy. I get that it's really a reach to think that we as a community can work together to change the kind of care we deliver. But I love this quote, because this is what a career should be based on. This is what your careers should be based on. We got a healthcare system that was kind of broken. Let's fix it. And that's what Strong for Surgery is all about. So I want to introduce my friend and colleague Tom Varghese, who's going to tell you about Strong for Surgery. Tom's a thoracic surgeon, he's associate professor, but what I know him best is like a gentle giant. No offense, you're a pretty big guy. He's a gentle giant who can get up in front of a room of people with lots of gray hair, senior surgeons who've been doing it this way for 40 years, and talk about what it's like to change the culture of checklists in the operating room. We had a problem in my hospital with things that were left behind. We're solving that problem. We're solving it by being honest about it, by working together, by being partnered with each other, by not, burying it under the ground. And Tom's leading that initiative at the UW Medical Center. I can't think of anybody better to help inspire you to the idea of Strong for Surgery than Tom. And so Tom, why don't you come up and tell them a little bit about this initiative?
You know who you are. Sometimes he has an identity problem. So he just put his name to remember.
Gentle giant. I'm still stunned by that comment. Thank you, everybody. Good evening. As Dave said, my name is Tom Varghese, And it's truly an honor and a privilege to introduce this campaign, this Strong for Surgery campaign, where in essence, as Dave boiled it down to, it's the concept of moving the checklist initiative that each and every one of you participated in from the operating room to the preoperative setting. Each and every one of you were involved in introducing the checklist initiative in the state of Washington. But a checklist really isn't just a 3x5 poster that hangs in the wall. Even though that we've got 100% compliance, really a checklist is a list of evidence-based measures that enforces a culture of safety. Without following these different steps, we don't guarantee the safety of our patients from the operating room onwards through the post-operative recovery. But as we start thinking about the checklist or things that impact or factors that influence the outcomes of our patients, we start to realize that there are other individual impact measures that influence those outcomes. Patient factors, the health of the patient, your shared decision making, that discussion in your office. Is this an appropriate surgery to perform? How do we make you better? How do we make you stronger for that surgical outcome? And then onwards onto the operating room. Until date, the entire focus that we've been doing is in the operating room. But the concept for the Strong for Surgery campaign is really shifting that spotlight from the operating room to the doctor's office. That is where the decision takes place. That is not only the decision for the operation, but how do we make this patient stronger for the surgery and thereby improve the patient safety outcomes. A lot of the measures that we're thinking about for the Strong for Surgery campaign is really obtained from discussions from the community at large and from the community that's sitting in this room. That is things like for diabetics, that is blood sugar control to prevent infections. Stopping smoking so that you thereby decrease the outcomes for pneumonia. Beta blockade, thereby preventing heart attacks. But this fourth concept on the list is something that isn't really talked about, and something that I want to explore further in the next slide. That is nutritional interventions to avoid complications. And really when you start digging into it, nutritional impairment is the leading cause of complications and death in surgical patients. And when you look further at it, really all patients having surgery should be assessed. You know, not only are these other measures that we're thinking about approaching in the Strong for Surgery campaign, but also as well as for nutrition. And it helps to have a conversation about risk. That is, that if you can identify those patients who are nutritionally impaired, thereby you can then start approaching how do we get them stronger for the operation. 8 randomized clinical trials have demonstrated that patients do appear to benefit from supplements across the spectrum of nutritional standards, and thereby leading to about a 41 to 50% risk reduction. There really isn't any other area whereby you can really influence that outcome in such a dramatic effort as addressing the nutritional status of the patient prior to surgery. And so really the goals in this coming year, we're taking a look at one of those 4 targets that is really looking at the nutrition target. And really we're focusing on these 3 measures. We want to universally measure albumin. Now, albumin is not a perfect surrogate for nutritional status, and we know that. But albumin measurement is not only in the SCOPE campaign, in the Strong for Surgery campaign, it's also present in the NISQIP campaign and other campaigns that are out there. And I think it's an important step in terms of identifying those patients potentially at risk for a complication. Preoperatively, I come up with this checklist whereby you can identify those patients nutritionally at risk. Not only identify them, then take it to the next step. If we identify those patients, what do we do about them? How can we address those nutritional impairments, make them stronger for the operation? And then increase the use of appropriate evidence-based interventions to boost up that nutritional aspect, really make them strong for the surgical outcome. And so this slide really is a reflection of many of the themes that you've heard talked about tonight. This is the slide that you can take Dr. Hoyt's introduction and everything and really apply it to this side. Those 4 steps sitting over there for the American College of Quality Initiative. That is, finding out what those standards are, those evidence-based standards, building out the infrastructure, capturing the data, and then in a peer-reviewed manner, analyze that data, thereby you can do the interventions. And so really, that's what's building out on this slide. Building awareness. Building awareness is events like tonight's event, and onwards to our May 14th annual SCOPE retreat. Identifying those best practices. looking internationally and finding out what we can learn from all our colleagues across the world, finding out what those best practices are. Really serving as a certain network, really serving as a repository and distribution network whereby we can share out these best practices. Really going in a deep dive at selective sites, volunteer sites, that will allow us to come in and really analyze that flow, finding out where we can intervene, where we can find out, where we can learn from each other, then thereby going into the distribution network and sharing those best practices. And then, as we've always done in the scope machine, so to speak, that is tracking and then measuring where we can do improvements. Many of these same themes, as I said, we've heard about tonight, many different industries, and I think it's just a natural fit that we continue these towards a Strong for Surgery campaign. The Strong for Surgery campaign would not be possible without our partners. The Education Division of the American College of Surgeons, AHRQ, the Life Science Discovery Fund, Nestle. There are a lot of partners that are involved in this Strong for Surgery campaign, but really it wouldn't be possible without the scope of community, and that's each and every one of you. All of you have got us to this point. We can learn from each other, and I think that this is an important launching point whereby we can take this to the next level. That is that the Strong for Surgery campaign, and really going and telling everybody internationally, Washington, D.C., that we can do what's best for our patients in the state of Washington, nationally as well as internationally. Thank you.
Thank you, Tom. I can't tell you how much I admire you just for the things that David said. I remember when I was recruiting Tom, he had just finished the training at the University of Michigan, and he was talking with that kind of passion in front of me. And most people somehow it seems like I'm an ogre or something. When they're in my office alone with me, they are very respectful. Nobody calls me Carlos. So we talk to Pellegrini and all that other stuff. And he was sort of more aggressive, and I said, is he full of bullets, or does he really mean it? I think that time has really shown that you really mean it, and you're great to have as a partner. So may I ask the panelists to come to the front? And may I take, while they are coming to the front, their bios are in your program, so you can see all of them who they are, but I will just point them out once they sit down. May I take some credit, Nancy, you've been to several of these. We have been on absolute time, perfect time performance, right? So Ellen Farouk is sitting here to your left, and Ellen is now the new medical director of Scope, and we welcome her on that road. And I'm going to ask him some questions, and I'm going to ask you to think of some questions that you may want to have. Oh, Brad and Keith, you don't want to come to the top? We have 2 extra chairs. Don't we have 2 extra chairs for that? Perfect. Yes, we want your comments. We want your comments. We want you to react to what they say. And so they will react, and we have time planned until 8:15. And so we have 30 minutes for questions, for answers, for interactions with all of you. And I really encourage you to make use of that time. And I encourage our aviation partners to react to what happens here.
They do have some remarks.
Well, they have some remarks as well. Am I supposed to start with their remarks or with questions? Perfect. Perfect. All right. I thought I had missed out here. So, Ellen, first of all, prepared as you are, tell us how, as a medical director of Scope, you see Scope and certain mixing with those 4 items that David told about the Inspiring Quality Campaign. How does the Inspiring Quality Campaign and Scope are intertwined?
Thank you. I think that Scope and Certain are wonderful partners. I think that they both benefit each other to advance the purpose of the college, to inspire quality, to make surgery safer, to expand our checklist, to think about why we do surgery and who we do it on. I think they're patient-focused, which is very inspiring. And more than that, as I look out in the personally, working through scope and working on certain, I'm confident that this state will lead this for the nation. Very confident.
So I think I started wrong. I am told that each one of you has 2 or 3 minutes to make some comments. Now, 2 or 3 minutes. Is that correct? So assuming that that is correct, I will move to Richard and ask him, because I know that he never stands quiet. Make your 2 or 3 minutes comments, or I will ask you a question.
Actually, my preparation work has the question you're supposed to ask me right here.
All right.
So go ahead and ask the question.
So, should ask the question and answer the
Carlos
question.
is supposed to ask me, I work at Virginia Mason, what we do at Virginia Mason for quality. And I think most people in this room know that Virginia Mason bought into the Toyota production system, hook, line, and sinker, about 10 years ago. As it turns out, because of the relationship between our executive leadership and Boeing's executive leadership, they bought in as well, and it really turned the company around a couple of decades ago. There are two pillars of the Toyota production system that really are relevant to this discussion. The first is Mr. Ono, who really took Toyota to the top. The lean philosophy, or I prefer to call the elimination of waste, and the term is muda, Japanese for waste, and Mr. Ono came up with 7 elements of waste, which are almost exactly duplicated in an editorial written by Don Berwick and JAMA this week about waste in medicine. It's almost straight out of the Toyota book. The second thing is the approach at Virginia Mason of patient safety, which I think is relevant to these databases going forward. And the philosophy of safety in Toyota, they had a relentless pursuit of safety. And they've got a philosophy which is, I think, extremely relevant, and that is that mistakes are different than defects. We all make mistakes, but defects are what people focus on, and that's what I think patient safety people in medicine are focused on are the bad outcomes, when it's really more bang for the buck if we focus relentlessly on mistakes that do not result in errors. We have a patient safety alert system. There have been 26,000 patient safety alerts filed at Virginia Mason in the last 10 years. 26,000, that's 7 a day. And about 90% of those are just small mistakes that a care provider, a technician, a transporter, a doctor said, I didn't like this. They pick up the phone and they call in a patient safety alert. 2% are what are called red PSAs, where there's really harm to the patient. And 98% of our effort really is related to these small errors. They're not defects, they're mistakes. And I think that's something that we just need to have in the back of our mind when we come up with these databases. How do we really improve patient safety by, and we do that in scope. I mean, we track, death is not a good outcome to track complications. The mistakes we need to be tracking are errors in glucose control, errors in remembering beta blockers, stuff that David is hammered home. And I think that's, time is up.
Perfect. Thank you very much. Some reaction from about that 98% versus 2% from our aviation partners here, focusing on the little mistakes and the correction of that versus the loss of fuselage.
Yeah, absolutely.
You were passing the mic?
And the numbers are large on any given day. And like you say, the defects, okay, we'll worry that, but the human element, the human, since part of what Mr. Ono teaches is that humans link the system, people link the system, we have to be relentless about driving that out. And frankly, part of it is also how you deal with those human errors. Because if you then take a punitive approach, then the likelihood of those errors surfacing are greatly decreased if someone believes that it's going to be punished for misdrilling holes or you can imagine any series of errors, which are not only not conducive to cost of quality, but also could impair safety. So the way in which we treat those errors also is critically important. because we have to take them as learnings as opposed to for a reason to punish someone.
Carlos, I just say one other thing I think you guys are probably interested in. The breakdown of the categories of the patient safety alerts we have, 37% are systems errors, which obviously the most important, or is so-called latent errors. 26% are related to errors in diagnosis or errors in treatment. 20% are medication errors, and then the rest, which is about 15%, are either professional issues those, as a program director, those ones I get, my residents who are jerks, or equipment failures, things like that. That's a minority. Most of them are system errors and errors in diagnosis.
Perfect. So our next person scheduled to speak here is Scott Steele. And before I ask Scott to start, I would like for us to recognize Scott for his service to this country. Scott is currently active duty military, working at Madigan, not as a colorectal surgeon necessarily, but working to take care of the troops, and has been deployed several times, the last one in Afghanistan, from which he just returned. So Scott, thank you. I haven't asked the question yet.
Oh, you got a question?
I still outrank you.
That is true, and I have a photo of him in uniform for anybody who wants it.
What uniform is that?
With the beard.
I've known Scott for quite some time, since he was a resident, but you should see Scott peeling a banana. As soon as you see him peeling a banana, you know he graduated from West Point. They come one end, they come the other end, they come in the middle, and then they go in. So Scott, the question that we asked Scott to address is the role of education of residents, educating the next generation of surgeons on quality.
So I'm the Associate Program Director for Surgery at Madigan, and I think one of the challenges that we have is kind of incorporating quality into practice. And historically, for all of us who have made it through residency, we've always kind of equated quality or lack thereof to M&M conference. And that's very meaningful to residents. They can go up there and they can discuss the morbidity, their complication, and depending on the mood that I'm in, that is sometimes more meaningful than others as we walk them through that particular process. But being a scope and being a part of NISQIP and looking at the larger view of quality, it's how do we instill that in them to say, hey, it's not just about that particular patient, but how can we do things better on a little bit more of a hospital level, as a service level, and greater from there. So one of the things that we have partaken in is basically involving the residents in two separate things. One of them is having access to the ACS NISQIP data. And what they'll do as a part of their research programs is take a question that's in mind that may have sprung from a particular patient that they took care of, and look at what the data says within ACS NISQIP. Ask that data, look and see what that data says in this vetted data that goes to do the research question, and then how can we then apply those results, not only for a presentation or a paper out there, but how do we apply that back to our patients? So we're using that data that's involved in there, that is very high quality data, and then reapplying that back to the patients at hand. And we've looked at that for care of patients with anal cancer, for using minimally invasive tools in people that have very obese patients. Historically, we said, oh, we can't operate on that patient with a complex laparoscopic procedure because they're too heavy. But when we look at the data, those patients do better, and they can look at that data and they can reapply that to the next patient at hand. And the second part of the thing that we do is that, just like the surgical checklist that's involved in scope or many of the different hospitals, we've now involved residents in that process, and that process for us is called team steps. So at the start of every day, before they'll even bring a patient in the room at 6:45, resident and the staff goes over and we introduce ourselves, the anesthesiologist introduces ourselves, and we run through the list of the day, talking about what the patient is, what is the site of surgery, why are they there in surgery, what antibiotics are they going to give, and then any specific equipment that we'll need. So it's an extra step, it's team steps, but each of the different particular people, from the scrub tech to the surgeon to the resident to the anesthesiologist, partake in that, and it involves the residents so they can see that hopefully that the quality up front will lead to better patient outcomes on the back end.
Does everybody get specifically trained on team steps?
It is a mandatory part of the hospital. Yep, there is not a patient that's brought back in our hospital without undergoing team steps. And even if it's in the middle of the night, you have a team steps before that patient is brought back.
Team step. How many of you are using team steps or have used it? Nicole, Long, Harborview is using team steps. It's a program that has a lot of aviation into it. It's a program that the military brought in with the experience of aviation, looking at situational awareness, looking at communication, looking at mutual support. It's got 4 components, and it's a program that we're trying to now embrace as well. Very interesting program. Okay, thank you, Scott. Our next speaker is Maury Johnson, and I want to tell you that I met Maury shortly after I came to work at the University of Washington, now nearly 20 years ago. And at that time, Maury and his brother came because they were interested in specifically learning certain aspects of things that we were doing, and we established a collaborative relationship with the 2 of them. And it was through Maury and through his brother that I actually learned a tremendous deal of appreciation for the life of a surgeon in a community hospital. So I have been privileged to know the Johnson brothers of Skagit Valley, as many of you know. And so what we are interested in you commenting is how does all this fit the community hospital?
Well, Carlos, if you'd like to learn a little bit more about what it's like to be a community surgeon, we're a little short on surgeons, and we would welcome you on the hospital.
I go in April when the flowers are coming up.
I actually left Seattle to get away from the traffic, and all of you discovered Skagit Valley. So, at our hospital, I think a really amazing thing happened. And this started last summer, a simple conversation with myself and the head of our anesthesia department, Sean Sullivan. And I just said, Sean, we have to do a better job pre-operatively, intraoperatively, and post-operatively of glucose management. And I shared with him the data. And that was, talking to Sean Sullivan is he's a fertile field. As soon as you show him the data, he's on it. 2 days later, I met with one of our hospitalists, Jeff Spielman, and I had the same conversation, and then pointed out to him from our scope data how our current diabetic protocols, post-operative protocols, were missing, and our glucoses were high. Within a few weeks, the 3 of us came together. I provided an educational discussion to the hospitalists. There was total buy-in on them. We then went to administration, and in exactly 120 days, including numerous committee meetings of up to 20 different people representing pharmacy, nutrition, nursing, of course, the hospitalists, surgery, anesthesia. Starting this Tuesday, we are implementing our new glucose management protocol that involves not just colorectal surgery, but every patient that enters the hospital. And I think that it's really an amazing thing, because it actually, if you go through step 1 through 4, we have not completed 4 yet, because we're just implementing we've implemented step 1, 2, and 3. And most importantly, from the administrative level, we pointed out to them how much the savings we would generate, and as a result of that, we got staffing levels improved, so that instead of nurses being 6 to 1, it's 4 to 1. We increased the number of insulin pumps on the floors. We increased the number of glucose monitors, not only on the floors but in the OR. And it was a collaborative approach throughout the hospital. It started with one person asking a question, But finding, I would say, the appropriate physician champions and then administrative champions that we all joined arms together, and I think is quite a remarkable achievement in a short period of time.
Rick. And our last panelist is Rick Billingham. Rick is a colorectal surgeon here in the city of Seattle, and we've been in many ways partners for the day I came here. Rick was the person who introduced me to the Seattle Surgical Society at a time when they wouldn't let me come in. And Rick Thrillwig has another story in that, but we will keep with Rick Billingham. So Rick, on all your years of surgery, how do you implement culture change?
That's been one of the toughest things. Again, a parallel with the airline industry between the pilots and the surgeons, and each of these professions has an attitude. And it's sort of important to have the attitude of arrogance and competence and confidence to be able to take a 747 with 450 passengers, take the responsibility for this plane and these people and their families and their lives and all the lives that depend on them, and take it off in Seattle and land it in Tokyo. And the surgeons, one patient at a time, have to have this same attitude, simply to do their job, and become very confident in the ways that they do things, and it's awfully difficult sometimes to change. And it's interesting in my observation that when somebody comes into the operating room with a new gadget that really hasn't been vetted and really hasn't been changed, but the manufacturer's representative assures us that it's going to do a better job, we're very eager to embrace this kind of thing. With no randomized controlled trials, no comparative efficacy, and so forth. However, when we talk about perioperative care, which is another vital part of our thing to do, we've had randomized controlled trials on many things for over 20 years, and still surgeons are reluctant to change the way that they were once taught. And their mantra is always, well, I was always taught to do this by my professors, and by God, I'm not going to change what I was taught. So I think with regard to the gadgets and stuff, I think we as surgeons need to be a little more circumspect about looking for evidences of efficacy and cost effectiveness before we embrace these sorts of things. And regarding perioperative care, I think we need to be a little more willing to change and look at the randomized controlled trials. Some examples of these are 20 or more years ago, we've had dozens and dozens of randomized controlled trials saying that you should not use nasogastric tubes as a routine thing because they are detrimental, and yet still today in my hospitals there are surgeons who believe that they ought to have a nasogastric tube in and leave it a couple of days just for good measure because that's what they were taught. Similarly with early feeding. It used to be years ago that we didn't know any better and we thought that you had to wait for the patient to pass gas for 4 days before feeding them anything. More than 20 years ago, we had the concept of early feeding, and that was something that randomized controlled trials showed was better for patient care, diminished complications, and increased shortened hospital discharge and so forth. And yet there are still physicians in Washington hospitals who continue to wait for patients to pass gas before doing this because that's what they were taught. This has sometimes been called surgical Shintoism or ancestor worship. So I think one of the things that SCOPE has led us in is looking at some of the data. What are we doing? What are other hospitals doing? And we have, we're collecting data both on process and on outcomes. And but the culture change is going to have to come at the hospital level or at the caregiver level, where we look at these, we determine the standards of care, we check over SCOPE's large network to see if each of our hospitals is maintaining these levels of care. If we are not, if we are falling behind, then our colleagues at the hospital, in our departments and our divisions, need to bring this to us as groups and decide as groups we're not doing so good with glucose control, we're not doing so good with beta blockers when we should be, and have a commitment on the part of ourselves as arrogant surgeons to say, gosh, I guess what I was taught was not right. It may have been right at the time, but it's not the current standard of care. I'm going to change. And so I think that it's the scope process has been very important in giving this information to hospitals. And I know Dr. Florence and Dr. Horton, who are here from Swedish Hospital, have been champions of this process at this hospital. Again, it's expensive for hospitals to do this. They say, what am I going to gain by doing this? When I first went into medical practice, they said you got to spend money to make money. I think now the mantra is you got to spend money to save money. And I'm hopeful that our colleagues at the hospital administration level can understand this and see that the money that they're spending on quality control here is going to reap huge benefits both in patient care and in terms of the bottom line of money.
Thank you. Well said. Mike or Mark, do you want to add anything to the change in culture that Rick was talking about?
Rick did a perfect job, and we're going to try to.
It's a great job. It's not easy. I got a lot I need to learn from Maury. I mean, part of the deal with Maury is that we were just whispering here is that Maury's shop is this big and my shop is this big, and so those things that you're doing we need to do, but we need to find a way to do it quicker on a bigger level. And we are in full support and have been for a while. Now are tough times from a financial standpoint. So I think the way to sell this is what Rick just said, is that what we do is that we do this to save money, not to make money. Because right now that's what we're doing. I go to meetings all day to figure out how we're going to do that. I think this is a process by which we can get that done.
And the beauty of scope and meetings like this is that when we want to know how to do this and how to work on our problem with glucose control, who can we ask? Now we know we can ask Maury.
That's right.
Because Maury has reported to us that we are having some success in our hospital with this program that we've put in.
Well, maybe what you should learn from me is you just got to ask the right people, because I didn't have the answers, but I knew the question, and I just figured out who to ask the question to, and basically to find partners to help me solve the problem. And I think, you know, Mark, that's what, you know, I mean, absolutely right. It's a little easier when you're in a smaller system, but no less important.
Absolutely, and I didn't mean to.
Yeah,
I mean,
no.
Now I'm going to talk to you about exactly who you talk to, because it's hard to kind of wade through that quagmire right now.
Yeah.
One more comment about checklists. You know, we've had the concept of checklists is a recent one, but many years ago we had an idea about enhanced recovery protocols for speeding recovery after surgery. And among the instigators of this, one of the first people ever to write about this was Dr. Rick Thirlby, right here from Virginia Mason Hospital, about how can we get people in and out of the hospital, have them recover a little quicker, and so forth. So the perioperative, the intraoperative component was the second thing, and that's where the checklist came in from Scope and Atul Gawande and others. And now we're talking about, geez, we need a preoperative checklist too. And that's what Dr. Varghese had said, you know, here are the things that we can influence preoperatively to minimize morbidity and increase quality and diminish complications and diminish costs.
Do you have problems with culture change? Have you had to have culture change in big industries like Boeing, Alaska? Do you have any pearls of wisdom for us? Brad, it took a long time for pilots to come from the cowboy era to the, it actually took the 1977 accident in Tenerife.
You know, the thing that comes to my mind most recently is just the whole transformation of the airline industry in the last decade, and it's not, so I think the checklist in the aviation maybe been in place a little longer, but just the all the airlines that have filed for bankruptcy and the changes that were forced upon us by the marketplace, and basically getting our folks to feel like it was in their interest to come along with a smile on their face and focusing on our operation, on safety, and on customers and doing things right. It's we've got. I don't know if we have any expertise, but we may not have any good experience, but we got a lot of experience with it. And one thing I'll tell you we are doing is we spend a ton of time with people, Dr. Pellegrini. We spend a ton of time just sitting down and listening and talking about the industry, talking about the environment. And we have, one of the things we learned a long time ago is write it down. If there's a place that you're not today that you want to be 3 years from now or 5 years from now or 10 years from now, simplify it and write it down. And we wrote down goals for safety and for operational performance and customer service and financial returns. So we have no earthly idea how we're going to get there, but we've got to, because Southwest is there. And so we did that, and then we just started spending time with our people. And I think we're C students or C minus students on this or something like that, but it is all about the culture. It's something you need to be an A student.
All right. Now you mentioned Southwest. You're almost like David Flum, who comes to this audience with Keith Presley and shows an A319. I could have killed it.
It didn't go unnoticed. It's okay.
I just want to apologize. Okay, any questions from you?
That's right. It was one of those airplanes, one of those other airlines.
That's okay. Yes, sir. Ron, Mayor.
From a standpoint of experience and trying to get things to change, part of it was what Rick's pointing out is you deal with a bunch of cowboys that are pilots. So when you make the decision to go from starting engine 1 first in all settings and then 2, which is a difference, it's a change. And you have thousands of people in that process. How do you disseminate that? How do you reinforce it? How do you get it done quickly and minimize the confusion and still maintain your efficiency and efficacy during a process like that?
Great question. Brad, you want to?
Now that we've taken away the microphone. So can you, when you made it, how do you disseminate this and kind of push something?
Yeah, I mean, you make a basic change. The pilot's always going to start one engine instead of another one, which is different, like Rick was alluding to with surgeons. You know, I was taught to do engine 2 first.
Right.
There's thousands of people involved. There's all kind of processes. There are people that are on board against it, passive against it, active against it. How do you try and maintain efficacy and efficiency in translating that into practice?
Part of that actually might be easier or different in the airline industry. The cultural change in getting people to buy in, getting people to come along with some of these things I was just talking about is hard. And that's a different question. But if we want to change a checklist or change a maintenance procedure or something like that, we do base it on data and we base it on research, but we change the checklist. And we publish the checklist, and pilots and maintenance personnel, whomever, they're expected to follow the checklist. And the FAA, we are a heavily regulated industry. There's a certificate management office in Seattle with 35 or 40 folks that provide oversight to our company. And so if the checklist changes, our people, it's, I don't mean for it to sound like this, but we're required to follow it. So that's like when this engine start procedure changes, the checklist will go out, there'll be a bulletin, say the new checklist is effective on a certain date, and I think folks will do okay with that. But it may be that our industry is a little different.
No, but Keith, you talked about standardization of innovation, which is a concept that you know, doing something new. How do you?
Yeah. Well, to your point, and I absolutely agree with Brad. You know, he talked about 11 checklists during a flight. Since we are so checklist driven, to be able to republish the checklist with a new procedure, you're probably still going to have muscle memory on those folks who said, wait a minute, I do it over here. But if we're adhering to the checklist and everyone's working to it, then it probably lessens the pain of the transition. With respect to your question, Dr. Pellegrini, on what we're forced to do is the idea of a new gadget coming along, a new tool, a new tool suite to be able to use, and engineers like surgeons like the new bright shiny things, and that's what we want to gravitate to. But what we do on innovation is that there is a program schedule associated with any change, right? Whatever we're going to do, whether it's a large airplane program or whether it's a smaller thing, like I mentioned, the Boeing Sky Interior. But there are phases of that program. We call them the gated process. So there's gate 1, where we review the change itself. Is it feasible? There's gate 2, and that is, does the business case hold together? Gate 3, are we going to launch it? And then we go into production. And each one of those gates, of course, has its own checklist of what we have to do. The challenge, and it's probably not unlike much of what you do in your business, is that whether it's a specific patient or a set of patients, that sometimes the market doesn't want to wait for us to go through those gates. The market often wants to push that to the left and force us into not complying. And a great case in point is the 787, right? We had to get that airplane out, and the market was going to respond. And so therefore, what are the shortcuts that we take? And now we know, as we always did, that you have to go in with malice aforethought before you're going to change those innovative steps. Otherwise, you will be dealing with it much like the cost of quality. You'll be dealing with it at the end. And in our case, it was 3 years of dealing with that quality lapse with an engineering and a production cost. So there are very rigorous steps around how we introduce that innovation.
Are there any questions from the audience, specific questions? Yes. Wait for a second for the mic. And we're getting to the end, so let's make it short question, short answer.
You know, if you look at Boeing, I'm in the manufacturing business like you guys, much smaller, is that Boeing actually has a process that exceeds the requirements of their governing body. So Boeing aircraft gets made well in excess. Your own internal processes way exceed what the FAA requires. But what I'd like to know is of Brad, which is an amazing step, which I think has made Alaska the airline it is, which is an awesome airline today, is that you guys have discovered a methodology, and I'd like to hear what that is, for people that are not in command to actually come forward in a non-punitive manner. And I think that once you can actually have a non-punitive culture to actually come forward, maybe things will improve at a much more rapid pace. How did you guys put that in place?
Part of these programs, they're not mandated by the FAA, but they are by our governing body, but they are encouraged by our governing body. So there are programs that, ASAP programs that for pilots or flight attendants and mechanics and so forth, that there's a best practice in our industry just like there is in yours, and we're kind of encouraged to do that. The other thing I would say, and I am a little reluctant to bring this up, but our accident in 2000 has a lot to do with the company's culture today. We just said that can never happen again. And part of that, you recognize that people do make mistakes, companies make mistakes. We said, you said we want to have a reporting culture, and we want to have it safe for people to bring things up and work on them. And it was, I don't know, I think out of things like that, sometimes you make improvements. And I think if you talk to employees of Alaska Airlines and say, what is the culture around safety, most would tell you that the accident has a lot to do with how we operate today.
Isn't that something? David?
So I don't think there are any reporters here tonight, which is good for this point. Yeah. So here's a question for you. It's about public reporting. It's about the public. So I'm always amazed when I read the FAA reports about crashes or accidents or near misses. It's totally out there in the public. The pilot made a right turn. He was told to make a left turn. It's really out there, and you know, we do nothing like that in healthcare. And the argument's usually that we're going to get sued. There's a lawyer behind us waiting for that information to sue us. But it strikes me that aviation also can get sued, is also liable. Tell us a little bit how you've broken this barrier. You can be so transparent with the public, and we can't even go there.
So the fact of the matter is that a clear and cold, dispassionate view of the data, even during the process where we're leading up to root cause, is absolutely essential. It is in our best interests, whether as the airframe OEM, whether the operator, it doesn't matter who you are in the system. But the absence of that dispassionate dissection of a failure of that kind of magnitude it is in everyone's best interest to go that. So it really is being woken up one morning, 1 January, when I was the chief engineer on the 777, and getting the call from our team that says an airplane's crashed. It was a British Airways 777, landed short of Heathrow. Fortunately, no one died. But the process that kicked in, no one drops into their defensive crouch of, it's not my problem, it's yours. Because at the end of the day, we will all suffer if that's an outcome. Everybody will. The public will, our brand, the brand of the industry. So it's ingrained. In fact, when there is an Airbus crash, Airbus and Boeing share the information about what actually occurred. At that point, we are collaborators, not competitors. Because when an Airbus airplane crashes, that's not good for Boeing either. We need to understand what happened there so that if our design practices are similar enough or our operational practices. So I think that aviation has grown up in an era where the magnitude of the failures are so significant that we know that we have to approach it with that discussion. I don't know if there's anything
The only thing I would add is you've got to believe that you're better off reporting this stuff early and dealing with issues that are small than waiting for the problems to get big and dealing with a bigger problem later. If you believe that in your culture, you'll have that bias towards putting it in the open early.
And I think we as surgeons, you know, we don't have perhaps as much ownership of the brand of surgery as these people seem to have.
Well,
and as the truth is also the regulating bodies that were there, because everybody knew after the Alaska 261 accident, everybody knew the bolt, the size of the of the screw that was not measured, who did not measure, how wide did they measure, how many months have elapsed. So it is something from which every operator of the MD-80 then changed its practices because of that.
Right.
And yet, I have always been fascinated by that and by the fact that we are in such a similar situation, and yet we will never publicly disclose those things.
There's one thing I'd like to add. We're going to get sued anyway. Right? We're going to get sued.
If you ask these, I want to hear what these guys say about the same thing, because we're going to get sued anyway too, but we don't do it. We don't do this kind of public airing of the issue.
I'd like to ask Dr. Thurlby about this and his institution, because you had a never event a while ago that I think changed the culture, at least publicly, in terms of your attitudes toward disclosure and early disclosure and, you know, calling everybody and telling them the truth as soon as you knew it, and without a blame category. And I wondered if you could say something about that.
Well, that's true. I mean, we pride ourselves on our transparency with patient safety. That Benny talked about was a interventional radiology procedure where HIPAA was injected intra-arterially and the patient died. Clear HIPAA cleanse. And we basically called the Seattle Times and said, we really screwed up. This is what we did. This is what we're going to do. We have a patient safety award named after the woman who died. So I think it's not just lip service. We really do have an internal transparency. If we make mistakes, we tell everybody about it. There's this, you know, the culture of no blame. That's a harder nut to crack than you think, though. The individuals who made the mistake, even though we tell them it's a systems error, that's not the way they feel. I think just deny that is not being honest. We don't have an external transparency, so much, which was what you're talking about, or Carlos is talking about. We don't call you up and say, hey, this is what we did. What do you think we should do to fix it? But I do think, I'm drinking the Kool-Aid. I think our administration has really hammered this home. We have a very transparent patient safety system internally.
Okay, with that, I think I would like to acknowledge a couple of people and then conclude. And the first person I wanted to acknowledge is Craig Brownson, because I think Craig, of all of us in this room, for this event, has done the lion's share of work and has absolutely made Scope shine. So would you stand up? Fantastic. Anybody else working for Scope here who's not a physician? I see some people that are working for Scope. Would you stand up? Who's working for Scope? Not a physician. Nicole, you are working for Scope. Not a physician. Rosemary, you are. Why don't you stand up? So that we are extraordinarily proud of you, and as you saw Congressman McDermott is extraordinarily proud. He says he's going to go back to Congress and tell them, in the state of Washington, that is what we do. And that is a quality effort. And we really thank you for doing that, as we thank the physicians as well. But I think the people that make this engine go all the time is you. So I want to thank our aviation partners. I think you brought a lot to the table. I know that you said, Brad, you were very surprised that you came here, but I think this was a great exercise and hopefully the beginning of a long-term relationship. I want to thank my partner here, David Hoyt, the executive director of the college, who traveled from Chicago exclusively to be here with us and share this, and all the representatives from Swanwick who have, like Nancy and others here, helped us put this event together. And with that, right on time, I thank you so very much for coming, and I wish you